Good afternoon, everyone. At the outset, I would like to thank Amit Goel sir for giving me this opportunity to talk about the hepatitis B virus reactivation. So, to start with the introduction, so when we talk about hepatitis B virus reactivation, we talk about either true relapse, that is the virus and the viral particles have disappeared from the patient's body, and now there is reappearance. And second is acute exacerbation of the chronic hepatitis B. That means there is a baseline suppressed viral load in the patient, and now there is increase in the viremia. It could be spontaneous, but most of the time, the reactivation, when we use the term reactivation, it is usually associated with immunosuppressive therapies or the directly acting antiviral for hepatitis C and hepatitis B virus co-infections. This reactivation with immunosuppression, the rate could be as high as 41% and 70%. So, especially in patients who are undergoing immunosuppressive therapy or are about to undergo, this reactivation becomes important. How do we define hepatitis B virus reactivation? So the guidelines slightly differ in this aspect, but more or less, if we look at the 4 guidelines, we would see that if we know the baseline DNA, and if it was previously undetectable, then any value more than 100 according to APASL and INASL, and value more than 1000 international per ml according to ASLD. AGA is slightly stringent in this matter, and they consider any de novo detectable virus as reactivation. Similarly, if the baseline DNA was whatever with the baseline value, and if we consider true reactivation, then from previously detectable value more than 100-fold according to APASL and INASL, the lower two, and the lower two. Previously detectable more than 100-fold, and for ASLD again more than 100-fold, but AGA again is slightly stringent and it considers more than 10-fold increase in the from the previous detectable value of the viral DNA. So this is for HBs antigen positive and anti-HBC positive cases. We are not considering here HBs antigen negative. For HBs antigen negative cases, that is where the viral particles have disappeared from the body, any de novo development of DNA or HBs antigen or HBe antigen according to AGA is considered as reactivation. So as far as reactivation definition is considered, first is we need to look at HBs antigen status, then we need to look at the DNA status. If previously DNA level was undetectable, then more than 100 according to APASL and INASL guideline, and if we are following ASLD, then more than 1000. AGA is slightly strict. Any appearance of DNA is considered as reactivation, and if it was previously whatever be the suppressed value was, any 100-fold increase is considered as reactivation, while for negative cases, any appearance of viral particle is considered as relapse. So pathophysiology, as sir has already described, once the virus enters the hepatocyte through anti-CP receptor, it localizes inside the nucleus. There inside the nucleus, it forms triple C DNA. Triple C DNA acts as a backbone. It either integrates with the host genome or it forms mRNA. mRNA is exported out. mRNA acts as template. It reverse transcribes and forms the viral particles. Again, triple C DNA, either it is formed and it forms the viruses go out, the viral particle, they assemble together in the ER, they are exported out, or they can work to replenish the triple C DNA inside the nucleus. So this triple C DNA, since it is integrated and it is in the nucleus all the time, it acts as the basis for the reactivation with immunosuppressive treatment in the future. Again, reactivation. So as it is, as we see with immunosuppressive therapy, once the immunity against hepatitis B virus due to any cause is reduced, there is enhanced HBV virus reapplication. And once the therapy is over, the body gets time for the immune reconstitution. There is increase in the immune activity. It starts killing the virus, and in process starts killing hepatocytes. So initially we will find a rise in DNA, and once the immune reconstitution occurs, there is a rise in SGOT, SGPT, ST, can lead to hepatic failure, chronic hepatitis, or acute hepatitis, which can or cannot resolve. Presentation could be silent reactivation, in which we get elevated viral load without overt enzymes elevation. Mild hepatitis, when there is elevated viral load with evidence of clinical, biochemical, and histological hepatitis. And then there is severe hepatitis leading to liver failure. So spontaneous reactivation of chronic hepatitis B, it is difficult to differentiate from acute hepatitis B. These statements I have taken from the nasal guidelines, nasal position statement, the Andaman statements. So in few generalization can be made. Spontaneous reactivation, usually the patient will have severe jaundice, higher INR, and high chances of liver failure compared to acute hepatitis B. But this is not absolute. Definitely it varies. And one important thing is that with spontaneous reactivation, the titer of IgM anti-HBC will be less than 1:1000. Again, it is not a absolute value, but usually the titer would be on the lower side compared to acute hepatitis B. So IgM anti-HBC is used to differentiate between the acute hepatitis B and chronic hep B. But with spontaneous reactivation, this IgM anti-HBC will reappear, but the titer will be not as high as we usually see in acute hepatitis B. So the reactivation is more severe, causes more liver failure, more high rise in bilirubin, more rise in INR, and higher chances of liver failure. This is one of the retrospective study from Serene group in 2006, and forms one of the basis for this nasal guidelines position statement. So they have taken the retrospective study again. So 49 patient in acute viral group, 30 patient in exacerbation of chronic hepatitis B. So AVHB is acute viral hepatitis B. That is the group 1, that is the white column, and group 2 is exacerbation of chronic hepatitis B. So what they found was that the patient in group 1, the E antigen positivity was more or less similar in both the groups. Anti-HBE, again, because it is exacerbation of chronic hepatitis B, so it was more in group 2. IgM anti-HBC titer more than 1000 was in group 1, and less than 1000 was more in group 2. And if we compare the DNA level, lower HBV DNA was in acute group, and higher HBV DNA was found in group 2, that is patients who had exacerbation of chronic hepatitis B. So yes, so exacerbation of chronic hepatitis B usually have higher DNA, they have higher immune reconstitution syndrome, they have higher chances of liver failure. So definitely screening and risk stratification becomes very important. So any patient who is due to receive chronic immunosuppression or cytotoxic chemotherapy should be screened. Screening is usually with HBs antigen and anti-HBC. And if we get any to be positive, we should do HBV DNA as well. HBs antigen positive patients are high risk, low risk are HBs antigen negative patients. Again, among the patient factors, the high risk are patients who are undergoing stem cell transplant and the recipient of B cell depleting immunotherapies. Moderate risk are doxorubicin and more than 10 mg of corticosteroid for more than 4 weeks. This is a busy table I have taken from APASL, which stratifies patient according to risk of the category of the immunosuppressive therapy that we are giving. So here again, the table is divided into two parts: hepatitis B, HBs antigen positive and HBs antigen negative. So the thing to be noticed here is that when the patient is HBs antigen positive, majority of the cytotoxic or immunosuppressive therapy become high risk. But once the patient is negative, then only stem cell therapy and anti-CD20 therapies, they are considered as high risk. So the patient who have chronic hepatitis B with a suppressed viremia, any cytotoxic therapy or immunosuppressive therapy would automatically become a high risk and patient would require therapy or primary prophylaxis. While if the patient is a true, you can say the negative patient, HBS antigen negative patient, and there is a risk of, we are preventing the risk of relapse, then only in high risk cases, that is patients who are to be who are undergoing stem cell transplant or who are taking rituximab or similar drugs, then they need to be treated. So management, this is again a busy slide. I've tried to incorporate the 4 major guidelines, and Indian guidelines would be in the next slide. So when we discuss about chronic hepatitis B, that is the patient who are first is screening. So HBS antigen positivity and anti-HBC positivity, these are the 2 things that we consider. If both are positive, patient is chronic hepatitis B, and majority of the guidelines, ASLD, APASL, AGA, EASL, they consider primary prophylaxis for patients who are HBS antigen positive, whatever be the immunosuppressive therapy they are undergoing. However, if the patient has resolved HBV, that is HBS antigen negative, but IgM anti-HBC positive, in those cases, high risk therapy, that is the rituximab and similar drugs, anti-CD20 drugs, or the patient who are undergoing stem cell transplant, they need primary prophylaxis. The only thing in which these guidelines differ is possibly AGA, which even in cases of chronic hepatitis B, they consider that in moderate risk patient, you can give on-demand PPX, that is primary prophylaxis, instead of the other guidelines which consider to giving primary prophylaxis in all patients with chronic hepatitis B, and to give on-demand therapy in resolved cases only, except for B-cell depleting therapies and stem cell transplant. If we look at the choice of drug, then entecavir and tenofovir, TAF, the data is not enough, and in ASL still consider TDF and entecavir as the drug of choice. Duration, most of the guidelines consider 6 to 12 months, except EASL, which consider 12 months for normal cytotoxic immunosuppressive therapy and 18 months for special situation in which patient is taking rituximab or patient is undergoing stem cell transplant. Once we have completed the 12 months therapy and 18 months in case of the beta cell depleting therapies, then monitoring. The monitoring, again, it is 12 months according to most of the studies, but EASL considers it will be 12 months for normal cytotoxic immunotherapy and 18 months for 12 months, actually EASL considers 12 months monitoring for all the cases, and in which the duration of monitoring is 1 to 3 months, and that varies from patient to patient. So looking at the Indian guidelines, it closely follows EASL guidelines. So prior to initiation of immunosuppressive treatment or chemotherapy, screen with HBS antigen and IgG anti-HBC. If either is positive, serum HB DNA should be done. If S antigen or DNA is positive, preemptive prophylaxis is to be given. If IgM is positive but antigen and DNA is negative, then these are low risk patient, and they can just be monitored every 1 to 3 monthly during the treatment. However, in high risk setting, preemptive prophylaxis should be considered, should be started. Management, again, 12 months in low risk, 18 months in high risk, and once it is withdrawn, continued monitoring should be done for 12 months, especially for high risk cases. For resolved HBV who are not on drugs, monitoring should be done at 1 to 3 month interval with S antigen, DNA, and ALT level to be done till 12 months. And drug of choice, and again, is tenofovir or entecavir. So concluding the same thing that we have discussed till date. So patient who is yet to receive an immunosuppressive regimen, screen. If it is negative, nothing else is needed. You can vaccinate if indicated. However, if it is IgM anti-HBC is positive, then you have to consider the risk of the patient. You have to assess that patient is whether to be undergoing on high-risk immunosuppressive therapy or not. If it is on high-risk immunosuppressive therapy, start antiviral. If not, then again, you have 2 choices. According to AGA, even moderate risk should be started. According to other guidelines, there is no need. You can just monitor them. And if S antigen and IgM anti-HBC is positive, even S antigen is positive or DNA is positive, then you have to start on antiviral as preemptive prophylaxis. Thank you. Any questions?